talk about radiation risk. This is actually a fascinating topic. And it's quite a conundrum, actually. It's made the news. It was actually in USA Today about 2 weeks ago. I was on a plane reading about this. This has made the front page of the LA Times. This is the front page of the New York Times. It was even in the Wall Street Journal, this concept of radiation risks. I want you to have a couple of facts that you get kind of stuck in your brain at the end of this half hour. Just a couple things I want you to know. Your risk when you get irradiated, okay, medically irradiated, is dependent on 3 things. One is the amount of radiation that gets delivered to you. Okay, so whatever the study is, the amount of radiation that gets delivered to you, how long it's delivered, so over what duration of time, and what tissue is being irradiated. Okay, that's sort of your amount of radiation dose you get. What's basically how long, the amount of radiation actually delivered itself, and the tissue it goes to. Your cancer risk from radiation depends on the amount of time of life you have left after that radiation. So that's obviously a bigger issue in younger people than older people. And then ultimately, we can actually calculate out sort of the cancer risk. And I'm going to get back to that in a second. You also need to know 3 numbers to give you a sort of a proportionate perspective of radiation delivery. A chest X-ray in general, by the way, the measurements these days are millisieverts, not millirems, milligrays. Used to be all cut. The current terminology is millisieverts. A chest X-ray overall, a 2-view chest X-ray is 0.1 millisieverts-ish. Okay, so stick that in your brain. You will actually take that 100-fold if you go up to a CT scan. Okay, an abdominal or chest CT scan is 10 millisieverts. So it's 100-fold more to scan than to get a plain film of the chest. And that's not the triple scan. How many of you have that new triple fancy schmancy? We do. That's 60 millisieverts. Between 40 and 60, depending on the size of the patient. Now, the third piece of information you need to know is increase of cancer risk. Your lifetime cancer risk increases with a total body irradiation exposure of 10 to 20 millisieverts. 1 CT scan of your chest or abdomen increases your cancer risk. That's the kind of milieu we're dealing with, and that's why it's made the press lately. And those of us who have been practicing a long time, we didn't used to scan 8 gazillion patients a day. We only had a few that we would scan. Now we scan everybody. And think about the things we scan for. Virtual colonoscopy. People that go get themselves scanned from head to toe, Oprah style, to see if they have something that's in there. People get scanned for lots of reasons. Pan scans. Those of us who work in trauma centers, it's just crazy. They pan scan everything. Our urologists want to know the size of the kidney stone. We scan the kidney stones. We scan little kids that fall down and have a bump on their head. We scan them. We scan everything. And the quandary we're in is we're weighing the immediacy of needing to make an accurate diagnosis today, because the life threat could be today, versus the theoretic risk down the line of cancer. There's a paper in here that's quoted. It's actually not an abstract. It's actually quoted by Brenner. It's on the first page, that talks about the current sort of cancer milieu from radiation. And it is estimated that 0.4% of all current cancers are from medical irradiation, and 70% of medical irradiation is CT scanning. That's where most of it comes from. It's estimated because we're doing so many more scans, and we all are. You know that the queue for the scanner is always almost the longest queue in the emergency department is the queue for the scanner. It is estimated that it will be up to as high as maybe 2% of all cancers at the end of this decade will be medical radiation exposure related. Most of those cancers will be leukemias, thyroid cancers, breast cancers. There will also be some lung stuff in there from where we radiate, but those are the areas that are at the highest risk. Brain cancer as well in kids. And one of the things I want you to sort of look at to give you some idea of the difference in tissue and how tissue gets irradiated, there's a little table in your handout there as far as radiation exposure. You'll notice that the head CT scan for children is 95 millisieverts exposure. The head CT scan for adults is 20. That is because a child's brain is very different than my brain. Okay, my brain is like half dead at this point. A child's brain is synapsing all the time. It's developing so fast. And you radiate a kid's brain, and you're getting into pretty big radiation doses to kids. So again, remember, the radiation that they get is not just dependent on how much they get from the machine, but the tissue that's absorbing it. And a child's brain is different than an adult's brain, so it puts them even at higher risk. So overall, the dose, just the numbers to remember, are 0.1 for a chest X-ray, 100-fold higher for a CT scan of the chest or abdomen. Okay, and then if you pan scan somebody, so you do chest, neck, blah, 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 you're getting into 40, 50 millisieverts. Cancer risk increases at 10 to 20 millisieverts. That's sort of just the ballpark issue here. So that's the general background of this. What do we do about it? If you get into some of the abstracts in here, I think abstract number 1 is fascinating, and I'm not sure what to do yet with this. But this looks at the risk of contrast reaction compared to the ultimate potential cancer risk. The risk these days with low ionic, kind of non-ionic contrast, low iodinated stuff, the risk of a bad contrast reaction is vanishingly small now. It's about 1 in 400,000. And yet, I don't know, most of us get consent for anything that has IV dye, right? If you have a contrast, you get consent. But we don't get consent for radiation exposure. Now, we don't yet, nor I don't think should we yet do this, because I'll tell you, that is a road I don't want to hoe. That one, I don't want to go down that road, because I have to then explain to somebody, you could have a life-threatening thing today that I can only diagnose with a CT scan, versus, yes, it may expose you to enough radiation that 20 years from now you're going to get that leukemia. But you may be one of the 999 of the 1,000 that don't get it, but you may be the 1 in 1,000 who does. And this will increase your risk of that. But how do I weigh that? Right now, we're not in the ballpark of having to do this. But I'll tell you, one of the things I read in the Wall Street Journal was from a law firm. It was an editorial from a law firm that talked about this. They're out there. They're trolling for new areas to mine in the malpractice area. And this is a great area to troll. How they're going to prove this, I don't know. But the reality is this is something that we have to think about. We're not in the informed consent ballpark yet, but we may end up there. Now, I'll tell you the thing that when I put this lecture together and I read all this jazz and this has become a big issue at our hospital because of trauma, and I'll get into that in a second. What it's changed my practice in dramatically is in 2 areas. One is head CT in kids. The other is spiral CT in kidney stones. The next paper looks at head CT in kids, and what I want to give you is some material you can use when you go talk to those parents that really want the CT scan when Johnny slipped in the kitchen and bumped his head on the edge of the cupboard and has a Goomba. Okay, and actually, if you look at the AAP guidelines, having an appropriate sized hematoma in a certain place of a certain aged kid is an indication to scan. We all know we way over CT scan kids, way over CT scan kids, and with the cancer risk, that's one thing. The other thing is cognition. There's a paper in here, abstract number 2, that was done in Sweden. And what they did is looked at kids who'd gotten radiated for cutaneous hemangiomas in childhood. That was what they used to do back when, because they thought it shrunk them. We know now they shrink on their own. They tend to go away on their own anyway. But they looked at the total amount of radiation these kids got, and they looked at kids in 2 groups. Actually, they were now adults because they gotten radiated in childhood. They looked at their scoring in school, and in Sweden, they all have to do military time, and they get a ranking and sort of job description based on scoring that they do on testing in the military. They found that the higher the radiation exposure to the brain, the lower the scoring in general. And the other area where this is becoming clear is in the leukemia survivors that we're seeing now. Leukemia used to be a death sentence for children, and we know now it's not. Actually, kids are surviving tremendously. It's amazing, the save rate in kids that have leukemia, but these kids are now adults, and they're doing studies on these kids now, and they're not getting into college, and they're having trouble keeping jobs, and they're having cognition issues because of the radiation they got as children for their leukemia. So there clearly is a cognition issue. So if you can't use the Johnny might get cancer thing, say, well, I guess a junior college is okay. I guess Yale's not something you really want him to. Harvard, nah. But junior college, that's a good goal. You get the cognition thing in there. This will help you. It does. It helps a lot. Those cases you don't want to scan, and you know that it's just not necessary. This is a great area to mine as far as being able to convince parents that they don't want to scan their kid. Trauma patients. Whole next set of guidelines looks at trauma patients. Abstract number 3 is actually from the UK, and it's one of those laws of unintended consequences. What they did in the UK is they formed these things called the NICE guidelines, which was when to image kids who have head injury. And what they ended up doing was increasing the number of kids by something like 24% who ended up getting scanned compared to practice prior and picked up no more injuries to do this. They calculated that they would increase the number of kids that got scanned here, again, by about 20%. And again, the cancer risk goes up significantly there. There are guidelines. Actually, abstract number 4 is kind of encouraging. We need this to happen. The radiologists have gotten together and decided to look at yields on scans in certain kinds of trauma. And we need this in a big way. Those of us who work in trauma centers, I'll come back to trauma in a second, but those of us that work in trauma centers, we need some sort of guidelines to rein in those crazy trauma surgeons that want to CT everything from stem to stern. It's just nuts. What they did in abstract number 5, I like. What they did is this: the trauma patient rolled in. They took those little detectors that all the radiology techs wear, those little detectors that find the amount of radiation. They clipped one here because of the thyroid exposure, They clipped one here because of groin and sort of gonad exposure, and they clipped one on the chest. And they looked at the amount of radiation a trauma patient gets, scanning-wise. Fascinating. The mean was 22 millisieverts. So if you are scanned at all, the mean is 22. Cancer risk goes up at 10 to 20. Bingo. One trauma, you increase your cancer risk. One poor guy had his thyroid irradiated to 58 millisieverts by multiple CTs of his neck and head. Remarkable. They calculated out that in 100,000 patients that they'd have 190 excess cancers, 13 leukemia deaths, and 42 excess breast cancer deaths, just from the exposure in this. And there's a paper that came out in March of this year in the Annals of Emergency Medicine that looked at 86 trauma patients, and they had an average exposure of 40 millisieverts. I mean, this absolutely happens. There's a couple other papers here that look at it. It absolutely happens. There's no question. So when you get in your car crash and they've strapped you down on that backboard and trussed you up like a turkey, the only words coming out of your mouth as you go in that hospital is, do not scan me. I am fine. Get me off this board. I am fine. Don't you dare scan me. Because they will. And they'll scan you 22 to 40 millisieverts worth. It's remarkable. They do it in kids as well. A couple of papers there, abstracts number 7, 8, look at it in kids. Definitely, and you would think that pediatric centers would be more sensitive to this. So if you work in a community hospital and you transfer your trauma kids to a pediatric hospital, a children's hospital, you'd think they'd be better. They're not. They actually exposed kids 22% more to radiation than did the community hospitals and these things. So they're not any better. And there is a thing that you need to know is out there. We have a brand new 64 detector killer scan. This thing is awesome. It's awesome. It reconstructs people 12 ways from Sunday. I'll tell you there's some pitfalls to it as well, but it's great. What they have though on these newer scanners is a thing called an ALARA setting. It's called the as low as reasonably achievable setting, where they can actually, based on the patient's weight, based on the kind of study that you're doing, it can calculate the minimum amount of radiation it needs to expose that patient to get the pictures that you need. So these newer scanners actually have some settings, and in children, that is particularly important to get tapped. Renal colic. We used to, the old days, we would get KUB. Those of us who are old have done I'm from the IVP era, folks. I'm like ancient. We used to do IVPs and look for stones and obstruction and colonization and all this jazz, and now we just scan them, right? Think you have a kidney stone, let's scan you. One poor bugger in study number 9 had 18 scans for kidney stones. 18. 10 to 20 per pop. That puts him at 200 millisieverts minimum. This poor guy, and think about it. It is a recurrent disease, right? It happens, they get stones over and over again. Should we be scanning them every time? I absolutely have changed my practice based on this. Absolutely. These days, all I really care, if I'm sure it's a kidney stone, walks and talks and sounds like a kidney stone, especially if they've had one before. It's not the 55-year-old with the new flank pain. That person gets scanned because there are other things that can be terrifying in there. But what I really care about is, are they obstructed and are they infected? I want a UA to look at white cells. I can do an ultrasound and look for obstruction. I don't need to radiate them at all. And I don't need to know the size of the stone. The urologist may want to know, but I don't need to radiate somebody day 1 because odds are they're going to pass it. Okay, odds are very high they're going to pass it, and especially now that we're putting everybody on Flomax, odds are they're going to pass it. And if they don't pass it, they'll come back symptomatic. So I really have minimized my CT scanning for renal colic, and this one poor guy that got 18 scans, that is not unreasonable. I mean, that's not we can see that happening. We have people in our department who've had them 4 or 5, 6 scans for their kidney stones. It's silly. We shouldn't do that. Now, how about what imaging studies? So say the following situation. 26-year-old female comes into the emergency department. She is 7 months pregnant. She just got off a plane. As she got off the plane, she noticed that her leg was bugging her, abrupt onset, severe shortness of breath, pleuritic chest pain. You're worried about a PE. What do you do to work her up? I was taught one thing, turns out I was wrong. I was taught the wrong thing. What imaging study do you order? VQ? That was what I was taught. These days, it's actually not a VQ. The CT scan radiation to the fetus is so low, it's lower than the VQ radiation because what happens in that perfusion stage is you inject the jazz into her bloodstream. How does it get excreted? It's renally excreted. So where does it sit? In the bladder. Where's the baby? Right next door, knocking on the bladder, lying there on this lovely bladder full of radiation. It turns out the radiation exposure to a pregnant woman with these newer scanners is significantly lower than is the radiation from a VQ scan. So that's actually in one of the abstracts in here. The other one, though, think about it. What else did this woman have symptomatically that you could have gone for? Legs. It is worth, if you really want to minimize radiation exposure to a woman who might have a PE, start at the legs. And even if they're asymptomatic, they'll be positive 8 to 15% of the time. And then you're done. Right? You are finished. She has venous thromboembolic disease. She needs to get basically admitted and put on heparin, because that's what you need to do in pregnancy. So you have your diagnosis. So pregnant women, start with the legs. If that's doesn't give you the yield you would like, go for the chest with a CT scan. That's the least amount of radiation to the baby. And then, yeah?
Our department has first trimester do the VQ and then second, third do the CT.
I have no idea where that came from. He said his department has a protocol of first trimester VQ, second trimester, third trimester doing a CT scan. The radiation is low in any trimester. And actually, the radiation, I think what they're getting at is this whole organogenesis part of the first trimester. But it's still the radiation exposure is less with the CT scan. So I'm not sure. I'd love to see what their logic is for that protocol. Because as far as I know, it doesn't stand out. Anybody else have any? Yeah. It should. And actually, if it's done the way it's supposed to be done, if you look at the original protocols for VQ and pregnant women, they're supposed to have a foliant. They're supposed to, but they don't. I didn't think they just don't. So if you have a protocol where you have them with a foliant, then the radiation exposure is low. Because but it needs to get it. Until they pee out what basically, well, actually, that's a good question. I have to look that up. I'm not sure. I would imagine several hours because you have to get all of that dye out, all the radiation out.
We have a new protocol where they don't inject in nuclear medicine. They just do the inhalation thing. For
Okay. The other issue that comes up, and this is so should you be doing just a ventilation scan or just a perfusion scan? And I have to tell you, the perfusion scan is where the money is. And if they do just a ventilation scan, all they're going to know is there's part of the lung not being ventilated, but not why. Is it atelectasis? Is it an infiltrate? Is there some sort of Goomba in there that's decreasing the peripheral part to get ventilated? So the perfusion scan is the gold standard for calling it a PE, not the ventilation scan. So CT scan is actually easy.
What about MR?
Well, I'll talk about MR tomorrow because we have a whole thing on MR. It's still not quite the gold, the silver bullet, but it's almost there. We'll talk about it. That's a good question. We'll talk about that a little more tomorrow. Now, the last couple of abstracts in here deal with the hurdle. If you really get into this, I don't want to radiate my patients thing, which is it becomes a cause almost. What are our hurdles? They're endless. They are endless. But the one that I find the most interesting in this particular paper is number 14. If you work in a trauma center, you're going to have this paper used to beat you over the head to scan anybody who's a trauma patient. This is a paper done at LA County, USC, which actually Stuart Swadron and Maureen McCullough are from there, so they're the next two speakers. This is a paper that basically took trauma patients. Our trauma service loved this paper. It's a terrible study, but anyway, what they did in this study, they have a little mnemonic I like called VOMIT, Victims of Modern Imaging Technology. Only LA County, USC would publish something like that, but you gotta love it. They pan-scanned 1,000 hemodynamically stable multi-system blunt trauma patients. This is a prospective observational study. All they did was stand around and watch practice on 1,000 patients that were hemodynamically stable who had blunt trauma. They didn't set up any protocol ahead of time about what kind of things needed to be done. They just watched and saw what happened. 41% of these patients were scanned, basically due to, quote, an unreliable exam, which when you looked at what happened, the unreliable exam was it wasn't done. Hello, it helps to examine a patient. 59% were due strictly to mechanism. That was hi, we've got a guy here who was just brought in who was in a rollover. Okay, fine, scan him from head to toe, I'll see you later. Okay, mechanism only. The reason this is used as a hammer for those of us that work in trauma centers is they found, basically, in 20% of patients, scans that changed management. If you look at what the management change was, it wasn't going to the operating room for something they found. It was basically obsing them, or going back and doing a full physical exam, or doing a repeat exam over time. It turned out that most of these injuries that they found for doing scans really unnecessarily were things that didn't change management. They just admitted and obsed people when they otherwise might not have done so. You can decide that ahead of time without radiating somebody to death. This paper, our battle at our hospital this coming year is we've decided to go to the mat with our trauma surgeons and talk about the radiation exposure we're doing, because it is really, we pan scan everybody. everybody. It is absolutely ridiculous. And this paper is one of the ones that we're using basically back at them, because it isn't necessarily an indication to scan everybody just on mechanism. So let's summarize everything. You know the risks. Chest x-ray, 0.1 millisievert, CT scan 100 times as much. The risk over a lifetime is about 10 to 20 millisieverts, gets you about 1 in 1,000 risk of cancer. So that increases your risk of cancer. It's estimated that about 1 to 2% of all cancers by the end of this decade will be from radiation exposure, medical radiation exposure. That means 2 to 3 CT scans in a lifetime will put you in that category, in that increased risk category. There are no current standards of informed consent, but keep your ear to the ground. I suspect this is coming. Okay, I suspect this is going to come out there. Watch your helical CT scans for kidney stones and lower the bar, or raise the bar actually, for scanning kids. You now have some tools to use to convince parents. Pregnant patients with PE, start with the legs. If that's negative, go to a CT scan of the chest. And the bottom line to all of this is that we can't miss the current potential life threat or the current illness or injury. We have to get that stuff, but we certainly can minimize our scanning, and I think it'll help our flow as well. So any questions on radiation? Yeah?
Is there anything that you've read that correlates the epidemic of radiation exposure to the medical
The medical legal climate. Actually, there is some, basically it's not scanning per se. It is the risk taker, risk averse kind of person. And yes, there definitely are tests, there are absolutely scans ordered for.
American system versus the Canadian?
Well, that's a good question. But the thing for the Canadian, I know there's a couple Australians and a couple Canadians in the room. I think that if you look at even the Canadian guidelines for C-spine and the Canadian guidelines for head injury, their guidelines basically are meant to pick up surgical injuries, not just any kind of injury. So that's why their guidelines are significantly different, actually, than ours are for scanning heads or scanning necks. They want to know something that needs to be intervened on, and that is a different climate there.
We recently overviewed our rate of CT scanning, and it's actually about 25% of all ED patients.
Get a scan? Wow.
And actually, when our department, the director, looked at the data from nationwide, that's not that far.
Oh, no, I agree. I think that's probably true. I know ours is astronomically high. Yeah. By the way, just one more thing about this. These new scanners in particular, you now are in a weird place as far as, because we're busy, and you look at that end thing, impression, no aortic aneurysm. Phew, thank goodness. Except if you go back into the body of this thing, because these scans are so voyage to the bottom of the sea, you can practically see every molecule, they'll say, incidental adrenal mass, note possible cyst in liver, could be met, needs follow-up. Read the whole report these days. There's stuff hidden in there that is potentially important, not today, but to get followed up on. And please read the whole report. Don't go just to the impression, because you're going to miss some of those little incidental things that they don't mention down at the bottom, because you ordered it for one specific thing. So, yeah?
Does any of this translate over to your annual dental exam where they never give you thyroid protection? They do a Panorex every year as a matter of just click, click.
Actually, the Panorex has a significant amount of radiation. I don't have the number. A plain just one little tooth is it's like 0.01 or 0.001. It's really small. But the Panorex is significantly more radiation. And they do that for you annually? I want your dental plan. That's pretty awesome. Mine I have to beg, can I please, it's hurting, can I please? So,
They never give you thyroid cover.
well, and that doesn't make sense, because that's easy. I mean, putting the thyroid thing is easy. You can ask for it. So. By the way, if those of us that usually work in ERs, if you are around radiation, it's a fall off of 6 feet. So if you're 6 feet away, the exposure really drops. Okay, there's a distance thing as well. But if you're in there, please put thyroid covers on. It's just one thing you can do to save yourself, to help yourself in the lead thing.